So the question is, what do you do since you've transformed, you have internal data that proves value, you have maybe one payer who has worked with you cooperatively and is giving you risk-adjusted data and really confirming your internal data. Where do you go from there? How do you have conversations with within complex markets where you might have health systems that are going at risk with payers? You might have an ACO that's owned by some of the health systems in a market area. You may have independent physician organizations that are partnering with a payer to get better control of the spend. So you have all of these different people who are potentially going at risk to some degree. So if you have a new value proposition and you're a single practice, you can go to them individually, but they're not going to waste their time on a single contractual exercise. It's not very efficient for them. So they need a broad-based, across their network type of strategy. So the way that we're approaching this in southeastern Pennsylvania with VCCN is that we're selecting initially, selecting people who have the right cultural inclination, practices that have the right cultural inclination, to join the IPA. And now we have enough mass so that we can have conversations with an ACO. We can have conversations with different health systems. We can have conversations with primary care organizations who are going at risk. They're looking for value-based providers, and we can answer that call. We could not do it, however, as an individual practice, because in order to do this effectively, you need to have analytic expertise regarding claims data, utilization data, individual doctor performance, population health data. You have to have population health data so you can target populations at risk that we may overlook. We need that structure, and we need contracting capabilities that will allow us to progressively or incrementally go at risk depending on how well we're managing. We can't do that as independent practices. 10-person practices can't do it. 20-person practices, 40-person practices that don't have the infrastructure, the time, or the expertise. So the IPA model allows practices to come together, clinically integrate around the data, and then that allows us to collectively negotiate with payers. It avoids the legal and financial gyrations of a single tax ID number, and it's just as effective in terms of improving care and improving value.